Now we're going to see the electrolyte disturbance and some metabolic acidosis or things like that can occur on the postoperative period. First, for the sodium, we have hypernatremia and hyponatremia. So for the hypernatremia here, as a rule of thumb, is for every increase in 3 milliequivalent per liter in the concentration of sodium that be above 140 milliequivalents per liter, that is the normal concentration of sodium in the blood, then this is equivalent to lose 1 liter of water. So the treatment here would be the replacement with DS1/2 NS. This means dextrose solution in half normal saline. And if it is quick, the loss of this water that leads to the hypernatremia is usually in diabetes insipidus or osmotic diabetes, like in severe hyperglycemia, things like that. Then for the hyponatremia, we can have like two scenarios. One is when the patient is losing normal or isotonic solution, but because the patient is losing water, together with electrolytes, but the issue is that it's losing water, so the compensation is to restore water, like the antidiuretic hormone secretion and things like that. So for that, we are not excreting as much water as electrolytes, and so the patient has hyponatremia. The other would be with, for example, intoxication with water, in which the patient has hypervolemia. Also, this would include the inappropriate antidiuretic hormone secretion. And here the treatment is with normal saline for patients that are in the first scenario, because with the normal saline we are restoring the water, and that will ultimately restore the electrolyte imbalance, because the original problem for which we have the electrolyte imbalance was the loss of water with electrolytes, but just that the water we can retain is more than the electrolytes. So here what is corrected quickly is the volemia, and the tonicity will be corrected slowly over days, but there is no need to do any adjustment. We will just give normal saline. And for severe cases, patients that are symptomatic with seizures or coma, we would give hypertonic saline, like 3 to 5% hypertonic saline with 100 milliliters. Then for the potassium, we have again hyperkalemia and hypokalemia. For the hyperkalemia, we can develop it quickly, as when the potassium is dumping out of cells, like in crotch injuries or tissue damage or acidosis, and slowly when is, for example, due to issues with the aldosterone or things like that. So here the issue that the patient has hyperkalemia, so we need to treat this as quite the same as in renal failure. So we would give insulin, because this would put the potassium on inside the cells. We would give some resins that bind to the potassium, calcium carbonate, because it will stabilize the cellular membrane and prevent the patient from arrhythmias. And the hypokalemia, this is seen, for example, patients that have increased vomiting, emesis, or the nasogastric suction. Actually, the emesis would be the most common cause in the postoperative period, and this would present as a could be decrease in the potassium and decrease in the chloride, because in the vomiting we are excreting hydrogen chloride or hydrochloric acid. So here the treatment would be to replace with normal saline for the vomiting if it is too severe, but also the potassium we will replace it no more than 10 milliequivalents per liter, even though in some severe cases we can do it up to 20 milliequivalents per liter, but you would need a central line. Lastly, for a metabolic acidosis, the metabolic acidosis can arise secondary to the metabolic alkalosis could arise secondary to the prolonged emesis or the nasogastric suction and would present as a metabolic alkalosis with hypokalemia and hypochloremia. So hypokalemic, hypochloremic metabolic alkalosis. And the treatment would be to replace the potassium chloride with 5 to 10 milliequivalents per liter, and in severe cases, the chloride ammonium.